longer in the anemia category, and the plan was made for her to return next week for another follow-up. And the learning point here is the difference between high drops due to alloimmunization versus infection. With infection, once the infection is basically managed and the patient gets, or the fetus gets a transfusion, the fetus actually has very good outcomes, and they usually only require 1 or 2 transfusions, versus for isoimmunization, there's antibodies that's targeting the fetus throughout the pregnancy. So it's a longer course. And then this study was just looking at intrauterine transfusion of fetus with severe anemia caused by parvovirus infection, and found that the transfusion was performed mostly around the median was at 20 weeks, and overall survival rate was 84%. And there were fetus that were transfused as early as like 12 or 13 weeks. There was no difference observed in the outcomes. That's it.
All right, thank you, Ray. I see that Dr. Leiser has her hand up.
How common a procedure is this? How many do we do a year, and how specialized a center do you need? And then can you just expand on, we said the fetus was paralyzed?
Oh, yes. So for the actual number of cases that we do per year, I don't have the statistics. I don't know if Dr. Rosen can chime in on that, but I saw one during my last OB rotation in the fall, and we had this one during this rotation. So I've seen 1 per rotation so far, especially for like this study where they talk about doing it at an earlier gestational age. The skill of the person doing it is very important, so it would have to be at a more specialized center. Sorry, what was the second? Was that the second question? Oh, and the paralyzed. Yeah, the fetus was injected with bicuronium, which is anesthesia used to paralyze the fetus.
So of this study that you're referencing with 103 fetuses, in how many of them was the transfusion given into the umbilical vein, and in how many of them was it given into the baby's heart?
So I don't know the exact numbers of those, but usually when it's earlier gestational age, I think the cord would be small and may need to be injected actually into the peritoneal cavity. But for this case that I presented, the fetus already had ascites, so injecting into the peritoneum that already has ascites probably wouldn't have been as effective, and the heart was already dilated, so from the fetal status, so the heart was decided to be the place to inject.
May I ask a follow-up question? What does that mean, inject into the heart? Like, where are you injecting? Where are you traversing with your needle? Like, where is that going?
Yeah, so it goes, I don't know if this would play again, but it's injected into one of the chambers. I think for this one was the right atrium.
Oh, here, I can get it to play. I don't know if it played before, but here goes.
So Dr. Leiser, that's not our typical target. We almost always do these. The cord was so small, the umbilical vein, the intrahepatic portion of the vein, which we'll go for sometimes, is so small, and the heart was dilated because this baby fetus was fluid overloaded. That was the biggest target, and the one we thought we could get. That's a rare thing that we did. To answer your question, I think we've done 5 or 6 fetal transfusions this year. Most centers don't do that many, like Ken Louise in Houston does a bunch of these because patients referred from all over the country. But even at fetal centers like CHOP or Columbia, like when I was at Columbia, we did 4 or 5 a year. I have to be the doctor who did them. So no center has a tremendous experience with it. And ideally, we'd have one center on the West Coast and one center on the East Coast that did these procedures, but that doesn't exist, and we don't have those referral patterns. This is a skill that we happen to have here. We have all of our procedures written out and protocols, which actually were done our fellows, because we've had so many lately, have mapped it out really nicely. We have a set procedure for doing it. I think we are well equipped.
Thank you.
Yes, thank you, Dr. Rosen, and thank you, Ray, for an excellent presentation. Our grand round speaker, please go ahead and start trying to share. Thank you. Thanks, Ray. All right, so we're going to start transitioning into grand rounds in just a minute. I'm going to ask Dr. Ananth to introduce our speaker. But in the meantime, a word or two about attendance. We'll be taking attendance using the participants list at 8:10. If your name is indicated clearly, then we'll give you full credit for attendance, and the CME code will be distributed via the email system. And with that, Dr. Ananth, are you ready to introduce our speaker?
I am. So good morning, everyone. I am extremely delighted to welcome our grand round speaker this morning, Matt Hoffman. Dr. Hoffman is the Marie Pinizzotto Endowed Chair of the Department of Obstetrics and Gynecology at Christiana Care Health System in Delaware. By way of training, he completed his undergrad at UPenn, went to University of Florida in Gainesville to do an MD in medicine, and then came back to Penn State to complete a residency in OB/GYN, and then also picked up a master's in public health from Johns Hopkins University. Dr. Hoffman holds a professorship at the Thomas Jefferson University and oversees one of the largest obstetrical services in the country. Incredibly well recognized both nationally and internationally, particularly for his recent work on prevention of preterm birth through obstetrical interventions. His CV is pretty impressive. He has almost shy of 100 peer-reviewed publications. Perhaps the crowning glory is his randomized controlled trial on aspirin therapy for prevention of preterm birth, a trial that was done includes over 12,000 women in low and middle income countries, where he showed that prophylactic aspirin dose therapy reduces the risks for preterm birth, preeclampsia, and perinatal mortality. He's also the site PI for the Consortium for Safe Labor, a wonderful secondary data resource. His particular interests are in big data, predictive analytics, and digital outreach in pregnancy. I've known Dr. Hoffman for a really long time, and I'm sure many know he's no stranger to any of us. Incredibly talented, and he's also the site PI for the Maternal Fetal Medicine Units Network. And the most recent of his accomplishments is an incredibly largely funded randomized controlled trial looking at dose escalation for aspirin in pregnancy, which is going to be implemented through the Maternal Fetal Medicine Units Network. And as you may folks have seen his title slide, Felix, Hoffman, and the Great Obstetrical Syndromes. Is there a connection in the last names between Dr. Hoffman, who's our speaker today, versus the person who actually discovered the Great Obstetrical Syndromes? I think it is, but I know it is not. Anyway, with that ado, Matt, stage is all yours. Welcome again. Thank you for agreeing to present the talk today.
No, thank you. And just by full disclosure, I do not think I have a relationship to Felix Hoffman. As Ananth has sort of referenced, it's a pleasure to be back and working with the folks at Rutgers. It's been a great relationship, particularly with Ananth and Todd through the Perinatal Research Consortium and others at your institution. Felix Hoffman, for those of you who don't know, is the inventor of aspirin, and I'll spend a little bit of time talking about the great obstetrical syndromes and how many of the conditions that affect pregnancy are really placentally mediated, and that early pregnancy is probably underappreciated as a cause of many of the problems that we face, like preeclampsia, preterm birth. A couple of disclosures, some of which Ananth has already mentioned. I was part of the aspirin trial, which is an international consortium, and I'll be sharing some of those results. We followed that study up with some evaluation of the children called the aspirin neural follow-up study that was funded by Thrasher Research Fund. Ananth mentioned the dose escalation trial, which we're delighted to bring with Ananth and others to the Perinatal Research Consortium, looking at dose escalation that will be starting soon. Finally, I will talk about a study that I led called the AVERT trial, which was sponsored by a company called Seroprognostics. And I am not a relative of Felix Hoffman. I actually have looked at my genealogy. If there's a connection, it is far back in the past. Purpose of this talk, I'm going to break it up into a couple of acts, one of which is talking about preterm birth, and I'll share the saddest story ever told. Act 2 will talk about really the etiology of much of what ails us in pregnancy, talking about the placenta, particularly talking about a concept called deplacentation in the great obstetrical syndromes, something that I only became aware of in the last 8 years or so. And then we'll talk about aspirin, the oldest known medication. Well, we're just starting to learn about it. And from there, we'll delve into some of the clinical data supporting its use, safety, and cost effectiveness across a broader group of women, and historically what we have thought. Some of you may know this story, some of you may not. There was a group of reporters who, not surprisingly, were betting and drinking in the 20s. And they had a contest. Interestingly enough, this has now become an internet meme of who can tell the shortest story. And Ernest Hemingway won the bet with these 6 words: "For sale, baby shoes never worn." And what I like about this story is it reminds us how important an impact preterm birth is an outcome to the families and communities that we care for. So when we think about preterm birth, I just want to emphasize that over the last 30 years of my career, we have not made a meaningful difference. Important to look at the statistics, and this comes from the National Center for Health Statistics. There's 2 points to notice, one of which is though there is a little bit of variance in the overall preterm birth rate, what there really has not been is a change in the early preterm birth rate before 34 weeks. And this is what drives infant mortality and morbidity. It has been basically 2.7% for the last 20 odd years and showing little sign of movement. And if we can move some of these patients from the blue bars to the green bars, we'll have done a tremendous societal good. The other point that I just want to put into context is this is the way that we think about preterm birth in our country. We think about the relationship between gestational age and infant mortality. This is a classic study from Brian Mercer when he was at UT Memphis. And what he nicely pointed out is that the earlier you are born, the more likely you to die. So if you're born early, the death rate is exceedingly high. And by the time you get to 34 weeks, it's relatively uncommon that a child will die, at least from prematurity. Although this is the US context, it's probably important to pull back a little bit and think about it within the global context. So the red dots represent the groups that I work with in the global network. And in fact, where you're born may in fact be more important than what your gestational age is. So if you look at where the dark blue is, these are countries with over 250,000 preterm birth rates. And you look at the mortality of the 15 million preterm births that occur across the world, almost all of them occur within the sub-Saharan continent in Southeast Asia. What I think is important to contrast is in India, if you're born premature, 1 in 11 will die, versus within the United States, it's about 1 in 100. And if we can keep babies inside of moms, we can make marked differences in outcomes. And as we think about interventions, low cost, meaningful interventions like aspirin really have tremendous impact. I think the other problem, which the way that we think about prematurity, at least as obstetricians, is if the baby leaves the hospital, that is a complete victory. The reality is most of us are coming to recognize that in fact, prematurity is not just an acute event around birth. It really is a chronic condition. This is just a couple of instances that I've pulled from the literature. So if you look at children who are born at 34 weeks, they are missing about a third of their nephrons. And in fact, if we follow those children as early as age 12, we can start to see differences in hypertension. And we know if we follow those children long term that they have differences in stroke risk as well as renal failure. One of the ones that is also commonly thought about is neurology and neurodevelopmental outcomes. If you look at for every day that a baby is on some form of mechanical ventilation, they lose about half an IQ point. And when you think about some of the particularly early babies who are ventilated for days, if not weeks, this really has a profound impact. Even if we look at the heart and look at the anatomy of the heart, what in fact we see is that the heart of children who are born earlier are thicker, moved a little bit differently. And in fact, for each week a baby is born early, they lose about 0.5% of their ejection fraction. And although these things don't show up when children are 1 or 2, as we look at people over their life course, these are incredibly important things that can bear upon their long-term health. And really, we need to think about prematurity as not just the acute event, but really the long-term consequences. So I'm going to pivot a little bit, and I'm going to challenge a little bit about the ways that we think about preterm birth. This is James Carville, who famously during the Clinton campaign said, "Is the economy stupid?" This is Ivo Brosens, the inventor of the great obstetrical syndromes. Ivo passed this past year. Ivo got interested in the placenta actually as a third-year medical student. And what Ivo points out is, in fact, much of what is problematic in obstetrics is really related to the placenta, and particularly early placental development. So I'm going to pull back a little bit and explain what I'm thinking about and why I think the placenta plays an important role. So preterm birth, although we talk about it as a diagnosis, and when I go to morning report every morning, my residency used the word preterm birth, MAG, steroids, antibiotics. But if you pull back a little bit and think about it, preterm birth is really a common outcome that's driven by a couple of different things. When you look at pregnancy, there really are 3 different structures that we are mostly concerned about: the placenta, the uterus, and the cervix. I'm going to pull out causes from the uterus that we have long known to cause prematurity, namely multiple gestations, abnormal uteruses, particular uterine anomalies, and hydramnios. And I'm going to argue over the next couple slides that, in fact, the 2 predominant causes, and they're linked by the placenta, are really related to the fetus sending the signal, or the HPA axis, abruption, incisional hemorrhage, and then we're responsible for a number of these in terms of iatrogenic preterm birth, predominantly through growth restriction and abruption. And again, these, I will use the term ischemic placental disease, a term invented by my good friend Anum. But I will also argue that, in fact, PPROM and cervical insufficiency are also probably related, at least in part, to the placenta. So before getting into some of the more specifics and some of the clinical studies, I just want to pull back a little bit and challenge what I think we've all been taught in terms of the way that we think about pregnancy. When we talk about pregnancy, we talk about the first, second, and third trimester. And these really kind of represent the observations of our forefathers within the profession in thinking about it. When you think about it from a biological standpoint, there really are sort of 3 key events that happen in pregnancy. There's embryology, or organ formation, that occurs within the first 10 weeks. There's this period of placental invasion, we'll talk a little bit more about this in a minute, that occurs between 10 and 16 weeks, and then predominantly fetal growth. And this is one particular area that I think is underappreciated, is placental invasion. It probably plays an important role in terms of outcomes. So just thinking about the placenta and how it develops, one of the things to think about is, although we're all taught that our placentas are hemochorial, and in fact, we don't start that way in life. Humans, just like most creatures, start in what's called histiotrophic placentation. What does that mean? It means that the placenta actually sits relatively superficially for the first 10 weeks, and basically using nutrients that come from the endometrium and something called uterine milk, the fetus is able to survive. At that point, it begins to remodel, and there are 3 predominant parts, and again, one part is particularly underappreciated. There's a cytotrophoblast. This basically gives cells off to the syncytiotrophoblast, which is mostly what we think about when we deliver a baby and call the placenta. But there's also these key structures called extravillous trophoblasts. Just to give kind of a visual representation, this is a non-pregnant uterus. The dark purple is the myometrium. The light pink, if you will, is the endometrium. What happens in pregnancy is that the placenta begins to develop. And what happens is the maternal vessels actually become coated by these structures, which are extravillous trophoblasts. And in fact, these cells actually go in and migrate into the endometrium and have a lot of crosstalk with maternal signaling. And in fact, what happens is these vessels open up and provide a rich environment where it's high volume, low pressure. This doesn't happen. Classically, what you get is preeclampsia from that perspective. A little bit more about these extravillous trophoblasts. One of the things which is sort of an evolving question, is how does mom actually tolerate a baby? Meaning we know that half the genetic material is paternal, and how in fact does this process happen? What we're coming to learn is really there's an interesting process between the immune system of the uterus. So just like our lungs and guts have sort of unique immune systems, there is a whole set of innate immune cells within the uterus called uterine natural killer cells. The historical name for them was in fact Hoffmann cells. Other terms that have come up, which are called decidual macrophages. And what we know what happens in pregnancy is that the placenta launches these extravillous trophoblasts and they begin to develop, that there's crosstalk between the placenta and these cells and these immune cells. And then in fact, this relationship results in increased growth factors, dampens inflammation, and again, want to call attention to the word inflammation. And as time goes on, they differentiate and then they increase blood flow. This is probably a little bit easier to think about in terms of this. And again, thinking about the process of deplacentation. This is sort of Ivo Brosen's classic representation. Looking at a normal pregnancy, what you see is these large vessels that develop centrally and slowly wane. And at least in the case of preeclampsia, you don't get the same rich placentation. I stole this off of Miracle-Gro, but I think it's a pretty good analogy. If you look at the plant on the right, what you have is a deep, rich root system or placenta. If you don't have this, the plant dies. We call that stillbirth. If you don't have this rich system, you can pull the plant out easily. We call that abruption. If the plant has to be moved to another site to survive, we call that preterm labor. If the plant is in fact unable to grow successfully, we call that fetal growth restriction. So again, the idea that having a rich and well-developed placenta is key to outcomes. And again, although it clinically manifests itself across the spectrum of diseases, that in fact, it probably really all starts with the placenta. So this is sort of Ivo Brosen's fundamental tenet and where he came up with the word great obstetrical syndrome. And what he basically says is that if we don't achieve a good healthy placenta, we wind up with a continuum of outcomes. So going from partial development to completely absent development, you get preterm labor, followed by preterm premature rupture of membranes, growth restriction without hypertension, preeclampsia, preeclampsia with growth restriction, abruption, and eventually fetal death. So again, sort of a continuum, if you will, but a common etiology of placental development. Just going to pull a couple of studies demonstrating the role of placentation. These are two different studies from the group in South Korea who works with Roberto Romero. On the left-hand side, this is a study where they took moms who were normal, preeclamptics, and those in fact who had preterm with premature rupture of membranes. If you look at the percentage of vessels that were non-transformed, or if you will, not well-developed, in normal pregnancies, it's 6.8%. When you get to preeclamptic bursts, it's about half. And when you get to preterm premature rupture of membranes, it's about 20%. Again, resonating with the idea that early placentation matters, and that if you don't have a normal placenta, you wind up with these clinical outcomes. Going back just next year, they went back and they looked at preterm labor with intact membranes. And again, you see a very similar concept. This is normal vessels in normal pregnancies. This is looking at moms with preterm labor, and then much more severe in moms who had preeclampsia. This was replicated a couple of years ago at the group that I work with, which is a global network. They, in India and Pakistan, took babies who had died, and they looked at a mixture of babies who had fetal death, preterm labor, or term live births. They used something called the Amsterdam criteria, and I think this is important. What the Amsterdam criteria is a way of categorizing abnormal lesions within the placenta, but it also breaks it down in terms of mom versus baby. And what you see is a very clear pattern, and most of the lesions lie on the mom side. So in stillbirth, abnormal vascular lesions of the mom is close to 60%, preterm birth about a third versus about 15% in normal term births. And again, when you look at the type and severity of the lesions, much more common fetal death going to preterm birth, finally term birth, and relatively modest differences on the maternal side, suggesting that at least a large part of this process is maternally derived. Pulling back a little bit, we've sort of had clues to this for a number of years. When one looks at outcomes across pregnancies, one in fact sees that we've all known that moms who have preeclampsia in the first birth are more likely to have preeclampsia in the second. But it turns out they're also at risk for the other global obstetrical syndromes from that perspective. So what you see in these studies, and they're sort of all very similar, looking at moms with first birth versus second birth, be it preterm preeclampsia, you double your risk of preterm birth in the next pregnancy. Term preeclampsia, very similar. And again, it goes both ways. If you have preterm birth, you're about 3.5-fold higher risk of having preterm preeclampsia in the next pregnancy, and similarly term preeclampsia. So again, this says two things, one of which is these are probably interrelated conditions, and B, the mom is probably the important common element in them, and we need to think about mom and mom health. So what about aspirin? Aspirin is not a new drug by any means. If you look at aspirin, although Hippocrates is common given credit for it, in fact, salicylate, which is mostly derived from the bark of willow trees and myrtle, actually dates back to the ancient Egyptians in 1500 BCE. Hippocrates, the first physician, came up with the idea of using it in pregnancy, and he advocated for, in fact, boiling it as a remedy for pain during labor. From that perspective, so the predecessor to the epidural. Felix Hoffman gets credit for inventing aspirin. Again, probably may have been his mentor, not Felix Hoffman. Nonetheless, Felix Hoffman was a very dutiful son who worked at the Bayer company in Germany and attached a acetyl group to salicylic acid, creating modern aspirin. He did this with the idea of he wanted to help his dad, who had apparently had fairly severe rheumatism. Hoffman went on to have another famous discovery, and his quote-unquote success was diacetyl morphine. We call it heroin. He called it heroin because it made people feel heroic. The other part I just wanted to briefly touch on from an historical perspective is initially aspirin was sold as grains, and typically an adult dose would be the size of about 5 grains of barley. This is 325 milligrams in today's world. And then eventually, as they looked to provide aspirin for babies, they quartered it, coming up with quote unquote baby aspirin. And that's how we get this odd dose today of 81 milligrams. So although aspirin's an old medication, and we know a lot, we're still learning a fair amount about the way that it works and works in unique spaces. Aspirin works predominantly through 2 components, one of which is COX-1. COX-1 is a mediator that's mostly found in platelets. And in fact, when you look at aspirin's affinity, It's well known to affect the COX-1 receptor. And part of the reason why people initially became interested, and they thought that there was a ratio between thromboxane E2 and prostacyclin that was responsible for preeclampsia. It was well known in the 80s that these two chemicals were dysregulated, if you will, and it was thought that by giving moms aspirin, we could put this ratio back to being normal, and that we could prevent or treat preeclampsia from that perspective. The other way that we know that aspirin works is it inhibits the COX-2 receptor. And just digging a little bit beyond that, what it does is, in fact, causes a group of biologically active lipids to, in fact, make some compounds that, in fact, resolve inflammation. You and I historically have thought about inflammation as we remove whatever's causing the inflammation and it goes away on its own. Turns out it's probably a pretty regulated process by some anti-inflammatory lipids called special pro-resolving mediators. Specifically, there's something called lipoxins or aspirin-triggered lipoxins. There's also something called resolvins and a few others, and I'll talk a little bit of them. Interestingly enough, there's a receptor called the FPR2 receptor, and in fact, this receptor is expressed in a number of places in the human body, but one place it clearly is expressed is in the placenta, not surprisingly. So let's start off with the fundamental principle of why we thought aspirin would work in preeclampsia. It was thought to work by affecting COX-1, as I mentioned a few minutes ago. Just to mention, not everybody responds to aspirin the same way. There's long been known a concept called aspirin resistance, typically measured by something called thromboxane beta 2. And in the cardiology world, it's actually pretty well known that if you have aspirin resistance or not complete blockade of the COX-1 receptor, that in fact you get different outcomes in terms of cardiac events and death. Just to say, there's been a couple of studies that have looked at this in pregnancy and looked at the outcome of preeclampsia. There was a small Polish study looking at 43 women. In fact, they found that if you had not completely blocked COX-1 or aspirin resistance, that there was a difference in preeclampsia. But probably the much better trial was one that was done by the MFMU back in the late 80s and early 90s. And John Helm from the University of Alabama looked at women who'd been enrolled in that trial, and he measured aspirin resistance through this thing called thromboxane beta 2. What he found is, not surprisingly, women who took aspirin were more likely to have lower levels of thromboxane beta 2. But when you looked at whether they had complete or incomplete blockade, there was absolutely no association with any of the clinical outcomes of preeclampsia, preterm birth, growth restriction, and then just as a safety measure, grade 3 or grade 4 hemorrhage. Again, suggesting that this concept of aspirin resistance or COX-1 may not be so important. Just a point, I just want to underscore this, in thinking about populations, the group at Ohio State went back and looked at the same cohort. One thing which just to call attention to is particularly in heavier set moms, there is more aspirin resistance, bringing up part of the question, do we need to give our moms more aspirin? This is just briefly looking at those special pro-resolving molecules that I mentioned a few times. We know that if we block COX-2, we see that the biologically active lipids increase, specifically aspirin-triggered lipoxygenase 4, resolvin D1 and 3. They work through this receptor called the FPR2 receptor. And I'm not going to go through all of these different compounds, but these are all compounds in the basic science literature, which are A, linked to inflammation, and B, have clearly and consistently been linked to the outcomes that we've talked about in vitro models and in animal models of preeclampsia and preterm birth. And as a quick summation, all of these resolvins, if you will, special pro-resolving molecules, point in the direction that we would want them to in terms of improving outcomes. So are these things important, and how do we think that they're important, and what direct data do we have? Let's start on the left-hand side, which is the animal models. If you take a mouse model and you knock out this receptor, the FPR2 receptor, interestingly enough, what you get is preeclampsia. If you do the same thing, if you take a mouse model and you give it LPS as a model of preeclampsia, but you pre-treat it with lipoxins, you get less proteinuria, the pups become normal weight, and in fact, you have lower systolic blood pressures, again, suggesting that these may prevent preeclampsia, at least in a mouse model. And again, very similarly, when you look at preterm birth, if you give lipoxins before you induce inflammatory related preterm birth using LPS, you get much lower rates of preterm birth. On the human side, there's a little bit of data. Again, it's not as clear or as robust as we would like. The receptor for these lipoxin resolvins is very clearly found on the placenta, and particularly the extravillous trophoblasts, the cells that climb into the maternal decidua. There was an interesting study where they took CVS samples and they looked at the concentration of these receptors, and they found that moms who had much lower levels of these receptors, in fact, were much more likely to have a baby who was affected by growth restriction. And there was a study that looked at about 220 women, and they found that if you had low levels of lipoxin, you were much more likely to develop preeclampsia. This is probably the best study. This is again a case control study of moms who were exposed to either placebo or aspirin. This comes out again out of the MFMU study. And what it shows is in that study, which they gave moms relatively low doses of aspirin, 60 milligrams, starting between 30 and 23 weeks, what you see is moms who are on placebo, that their levels of lipoxins remain relatively stable, versus those moms who had given aspirin have much higher levels. And there was a trend, not statistically significant, to having higher levels of lipoxin in moms who didn't get preeclampsia versus those who did. Again, linking the idea that lipoxins and preeclampsia are probably intimately related. All right, enough biochemistry. Let's move on to the clinical stuff. Just going back a little bit into the history of aspirin, it's an interesting story, and part of, I think, our heritage has been, and limitation is that we've linked preeclampsia and aspirin from the beginning. There was a group of 3 obstetricians in California in 1978 who had a mom who had repetitive stillbirth associated with what was thought to be recurrent preeclampsia. When one goes back and looks at her case, she probably really actually, interestingly enough, had hepatouremic syndrome. They gave this mom 600 milligrams of aspirin 3 times a day, and she had a successful pregnancy. It's this case report that sort of indelibly links aspirin and preeclampsia together. This was followed up a year later. A group of English obstetricians who were all authors and gave the midwives no credit, not surprisingly, asked the group of midwives to go around their obstetrical units, asking moms if they had taken aspirin within the last 2 weeks, and found that those moms who had taken aspirin over the prior 2 weeks had about half the risk of preeclampsia. In the 80s, this then sort of became the age of doing a number of RCTs. These varied wildly in dosages and times of initiation. This was the first large one done by a French group, 102 first-time moms, gave a relatively high dose of 150 milligrams, also gave something called dipyridamole, which was thought to play a role in preeclampsia. They began early at about 3 months. And the moms who took aspirin with that dose, they found no cases of preeclampsia or major complications, meaning growth restriction or stillbirth. While in the in the placebo group, there were 6 cases of preeclampsia and 9 major complications in the control group and no side effects. What happens then is sort of interesting, and a whole bunch of trials start in the 1990s. And the first group to then sort of start to change the guideline was the WHO. The WHO recommended aspirin for moms who had high risk conditions. These are things you would think about: twins, diabetes, renal disease, hypertension. And it started a relative re-review of, is there a role aspirin in a population level? About 2 years later, Stephanie Roberge did a meta-analysis and pointed out really two things that I think are important. One of which is when she looked, she found an aspirin only worked before 16 weeks. Again, tying in with this idea that if it works, we need to give it early, and it probably needs to affect early placentation. What she also notices is it was not just preeclampsia that aspirin prevented, but it also prevented preterm birth, fetal growth restriction, and stillbirth. This led in 2014 the USPSTF to recommend low-dose aspirin for women with 1 high risk or 2 moderate risk factors. I love this particular quote that comes directly from their own publication, though the evidence for this approach is uncertain, meaning that they really were going out on a limb. They modeled out what they thought would be the incidence of preeclampsia in moms with 2 risk factors, and looked at the prior trials, and they wanted a group that had at least an 8% risk of preeclampsia to give aspirin. I just want to point out that today the risk of preeclampsia is well over 8%, probably more closer to 12% in the US. In 2014, a large trial was published out of NICHD. Enrique Schisterman took this concept of not only giving aspirin, but giving it early as being important. He published the EAGER trial in the Lancet looking at about 1,200 women. He started aspirin preconceptually. And in one of his sub-analyses that he noted is that there was a trend towards lower rates of preterm birth, about a 37% reduction. Just so that there's context here, it did not reach statistical significance. And it partly reflected that this was mostly a white college population who was actively trying to conceive. So putting it all together, what I want to do is just gently review the world literature and show just how heterogeneous it was up until this point of the EAGER trial. A couple of points just to make is there are a large number of trials. The doses vary anywhere from 60 to 100 milligrams. And again, the time that it's initiated is all over the place. So as early as 11 weeks to as late as 35 weeks. And again, if we think that it works by affecting placentation, probably needs to be given earlier. The predominant reason that people were giving aspirin historically was to prevent hypertensive disorders or preeclampsia. And when you look at this, what you see is most of the studies, in fact, showed no difference or a modest reduction in the rate of preeclampsia. What is really probably its effect, and I'll show some more data supporting this, is it probably only really works by preventing early preeclampsia, and that this is probably a different disease. And in fact, there's a very consistent story about preventing early preeclampsia, and again, maybe in particularly very early preeclampsia before 34 weeks. Again, aspirin, very similar story, probably prevents preterm birth, but may have more of an important effect in preventing early preterm birth before 34 weeks, where it seems to have a stronger effect, suggesting that we're changing some of the babies who may have been 31 weekers to 35 weekers in shifting the curve. This is what led us in the global network to think about taking a much broader view. And rather than thinking about aspirin in terms of preeclampsia, but to really thinking about it in terms of a preventative strategy for preterm birth. This was a study that was done in 6 low-middle-income countries: India, Guatemala, Kenya, the Democratic Republic of Congo, Zambia, and Guatemala, so very diverse population. And what we did is we decided to make it simple. All you had to do was have a single baby. You needed to be a first-time mom between 6 and 13 weeks confirmed by ultrasound, and then we followed you out. The outcomes of our study were pretty profound. So although we similarly showed a relatively modest decrease in preterm birth defined as 37 weeks, what we saw is we were able to drop the rate of early preterm birth, one that results in morbidity and mortality in these countries, by a full quarter. A trend, again, not powered to look at this before 28 weeks. Very similar to the graph that I just showed a minute ago. No difference in overall rate of preeclampsia, but statistically significant reductions of preterm preeclampsia before 37 weeks. I'm going to call attention to this number in just a second, a 62% reduction in early preeclampsia, a drop in fetal growth restriction by 87% in moms who had preeclampsia, and a reduction in perinatal mortality, all of which were statistically significant at a cost of about $2 a person. So this is really two different studies that we've chatted about. The top one is the ASPRI trial, which was in the New England Journal of Medicine. The bottom one is our aspirin trial. And what it suggests is, in fact, the benefit of aspirin is probably to delay preeclampsia, to delay early birth, not to prevent it. So this was a sub-analysis done by Nicolaides and Wright. Top group here is the aspirin group, which you can see is relatively uncommon early preeclampsia in the aspirin group versus the placebo group. And what you see is a nearly identical reduction in the aspirin trial that we did in that perspective, suggesting that what we've done is we've taken a lot of these folks who are dealing with preeclampsia here and moving them here, which is an important outcome to think about. What I think these studies point out is, in fact, preeclampsia, though we talk about it as being a single disease, it's probably really at least two diseases. This is a paper that came out in last year in the Great Journal. My good friend Sunit Chauhan says you need to Sesame Street it, so I've thrown in Elmo in this. And probably there are at least two different types of preeclampsia. Those with an abnormal angiogenic profile, so SPLT1, PLGF, something we've learned about over the last decade, very much associated with preeclampsia, and that these moms have a very different inflammatory profile than moms who don't have this. This tends to be early preeclampsia. This tends to be the preeclampsia with growth restriction, abnormal Dopplers, versus this form of preeclampsia tends to be more related to maternal age and obesity, and again, different inflammatory mediators from that perspective. When we talk about aspirin's ability, probably works here and not here. Going back to preterm birth, just to call out, a couple of other folks have looked at it from a trial standpoint. On the left-hand side is a prospective RCT that was done in the Netherlands. They took moms who had had a prior preterm birth. They assumed that they would have a 36% rate of recurrent preterm birth, and they could reduce it by about a third. They based this upon a study done in the United States in 2003. And although they saw a reduction in preterm birth and spontaneous preterm birth, it was not statistically significant, probably due to power. Similarly, Cynthia Giampi and her group at Columbia went back to the MFMU trial of the 90s, and they looked at moms who are on aspirin. And again, what they see is a near halving of early preterm birth, and again, a relatively modest effect on late preterm birth. Just to call out, there is a positive trend across the US. As a reminder, the guidelines in increasing prescription of aspirin started in 2014. And what you can see is, although the overall rate of preterm birth has remained relatively stable, early preterm birth, early gestations and low birth weight seems to be trending down from that perspective. A couple of other points just to hit upon. This is more of the implementation phase. With the changes in guidelines, it's important to recognize that we should be thinking about giving aspirin to most of our patients Following the publication of the new guidelines in 2021, Gita Swami's group at Duke looked at the U.S. birth certificate data in 2019. And what they pointed out that about half of women, in fact, more than half of women, should be considered aspirin from that perspective. And what they also point out is to prevent one case of preeclampsia, the difference between a risk-adjusted strategy is a number needed to treat is 1 in 63 versus 1 in 82, very similar numbers. The other point that I wanted to make, at least in the international context, and this is data that comes out as a sub-analysis of the aspirin group, is that in fact women who have risk factors and women who don't have risk factors equally benefit from aspirin. So if you recall the aspirin trial, we just took folks who were first-time moms, and when we compared those with just first-time moms versus had a second risk factor, which was predominantly Black race and obesity, that in fact aspirin was equally effective in preventing preterm birth, early preterm birth, hypertensive disorders, and perinatal mortality, with the exception of actually early preterm birth. The moms who didn't have a second risk factor, in fact, benefited more than the moms who had a second risk factor. And in this population, which is a relatively young, healthy population, about 2/3 of the moms would in fact not have received aspirin under the current US guidelines. Safety always a concern. This is data that comes from our randomized trial. Just to note, we did stop aspirin at 37 weeks. We closely monitored side effects, things that we've known about aspirin across the board. We saw absolutely no difference in any outcome except for a slight difference in rash that because of our large numbers was statistically significant. This is data from following these children up, recognizing that parents are often skeptical about taking medications in pregnancy. Again, remember we started as early as 6 weeks. We did a whole bunch of psychometric testing on these children, and in a very robust sample size, we saw no differences in cognitive outcomes. The only difference, which was sort of a trend, is in fact aspirin may have had slight benefit in terms of neurodevelopment around communication. As we're talking about policy, cost always comes up. And again, in low middle income countries, costs are very different. This is actually the average hospitalization cost for the neonates in these countries. Somewhere on the order of probably 2 lattes in this country. But even looking at these exceedingly low costs, aspirin is a cost-effective strategy across the population for daily or years of quality of life. The cost is about $13 to $29. So again, as we're talking to policymakers, this is important data to have. Finally, I'll just share a little bit of data that will be coming out in the near future. Both aspirin and vaginal progesterone have been suggested now in at-risk populations. There's now a blood marker that is out there by a company called Seroprognostics that is FDA approved. It is relatively sensitive with an AUC of about 80%. Although I can't share the actual results of the trial because they're still being evaluated. The AVERT trial, where we took about 1,500 women prospectively and tested them, and those moms who were positive or had an elevated risk by that test were treated with aspirin and vaginal progesterone. That showed a showed across both co-primaries of neonatal length of stay and a neonatal morbidity index benefit to this strategy. The second trial was a large trial where moms were tested, either given the results and offered progesterone and aspirin if they were elevated versus not shown the results. This trial was stopped early because it met its primary outcome at the first interim analysis. And again, this may be at least part of the future moving forward. Finally, the last big question that I think is out there is, are we giving the right dose? This is a study that is soon to be starting called the DEPT. This will come to the Maternal Fetal Medicine Units Network. We'll be looking at 1,800 moms who had a prior preterm birth due to a great obstetrical syndrome, concentrating on moms who delivered early before 35 weeks, randomizing those women to either 81 or 162 milligrams, looking at the rate of recurrent preterm birth, current ischemic placental diseases, and then some markers of inflammation from that standpoint. So in closing, deep placentation appears to be a cause of preterm birth and preterm preeclampsia. There is consistent evidence showing that, in fact, these diseases are all related under the title of the Great Obstetrical Syndrome. Most of us are now pivoting to think that maternal inflammation is probably key rather than affecting platelets. Aspirin is a potential treatment that probably delays but does not prevent preeclampsia or birth. ACOG and SMFM guidelines say that most patients should now be receiving aspirin, and that it appears to be a long-term safe medication for mother and child, and that is cost effective. And many of us think the last big question is, how much should we be giving our moms? I'm going to stop there. A pretty quick summary of aspirin and the work that's been done, and happy to answer any questions.
Thank you, Dr. Hoffman. Thank you for that excellent talk. Sir, what are the pros and cons of continuing the aspirin from 36 weeks until 40 weeks?
So from my perspective, there is no real evidence of benefit in that time period. There is some literature. There's 2 papers of note, one of which is one that comes again out of the Dutch countries, looking at a population-based study of moms who took aspirin. They show a higher rate of postpartum hemorrhage, and they suggest a higher rate of intraventricular hemorrhage in moms who took it, but it's based on 3 cases. And then there's another study that was presented in abstract form out of Yale showing higher rates of transfusion. I'll say we're pulling that data internally, but ACOG and SMFM do not recommend stopping, but other organizations like the WHO do. Enough?
Matt, thank you very much for that very enlightening talk. Why I keep hearing myself in echo. Anyway, so the ecological figure that you show on the slide is very impressive. Congratulations for dropping the infant mortality rate so much. My question is, the progesterone, when that paper came out in 2003, there was a subsequent follow-up paper applying the concept of a universal administration of progesterone supplementation in the United States. And Mark Klebanoff showed that if everybody eligible received progesterone in this country, that would drop the preterm birth rate by a relative 2% per year, which is, in terms of absolute numbers, it will drop the preterm birth rate from 10.9% to 10.71%, which essentially tells me that progesterone is not worth the effort, and time has proved that. Applying a similar logic, what would happen to the preterm birth rate in this country if prophylactic aspirin was administered to every person that's eligible? We can't hear you, Matt.
Sir, you're muted.
Sorry. So I haven't done the math enough, but it would go from about 10 to 11%. But more important would be the rate of early preterm birth, which would go from about 2.7 to 1.8%. And again, the morbidity and mortality, at least in this country, lies with that early group before 34 weeks. And that's where aspirin seems to be most beneficial.
I see a wonderful topic for a nice paper. could make a very good fellows or a residence project.
Yeah, I'll just comment. This graph is real. I didn't just make it up. This is NCHS data. And Christiana is the dominant hospital in Delaware. We do about 60% of the deliveries. But there's been a statewide initiative for routine screening and handing moms aspirin rather than telling them to buy it across the community. And we've seen our rates of administration go from about 20% to about 70%.
Wow.
I see that Dr. Rosen has his hand up.
Thanks so much for speaking to us. It's absolutely a great talk, and it's why you're one of my heroes in research. This is my question for you. I should turn off my camera. I look terrible when I'm looking in the one, please. But has anybody ever done anything super simple? I may have missed this while I was transitioning from my car to my office. But my question for you is has anybody ever just looked at the effects of aspirin on placentation in women who are who like terminated their pregnancies at 14 weeks? Like it would be really good to see what the difference is in placental, what the placenta looks like, and if we can get some biomolecular data or genomic or metabolomic data, that would be super interesting. Have we done something as simple as that, given that everything you're doing is based on the premise that aspirin affects placental implantation?
You know, it clearly has been done in vitro and animal models. It's not been done in human models. The mouse placenta is a reasonable surrogate, but not perfect by any means. I think would be great to look at from that perspective. And again, people are continuing to grasp onto this idea of early placentation inflammatory markers. Within the proposed study of the MFMU, we will be looking at inflammatory markers, as well as these lipoxins and others, to see if, in fact, we can see a difference.
Thank you.
All right. Well, Dr. Hoffman, thank you very much for this excellent talk. We very much appreciate it.
My pleasure. And if any folks have any questions, feel free to reach out to me. Anant and Todd know how to get a hold of me. Happy to help in any way. Have a good weekend.
All right. Thank you. So we'll end it there. I hope everyone has a successful and safe day.